It's my pleasure to introduce today's speaker, Dr. Anna Bedran-Russo. She's from the University of Illinois, Chicago, the Dentistry School there. That's a mouthful. But today she's going to talk about biomodification of dental composite materials. We certainly welcome you.
All right,
Thank you for coming.
Thank you, introduction. Thank you so much for all the reception today. It was really nice. I got to walk around a little bit at the Institute. I'm quite impressed. I was telling Scott and Nancy that we have a lot of our dental students in our dental program come from Champaign here, so I always heard about it, but I never had an opportunity to come and visit. So today I came to bring you guys a tooth problem that we have, all right? So my research has been, I'm a dentist with a PhD degree in clinical sciences. So we always see from the perspective of applied sciences here. So we've been doing some research in response to some of the problems that we find in dentistry, and hopefully they will be interesting for you guys as well. So when we talk about a tooth that's lost some function, either because it was broken or because there was some decay process, it requires for the dentist to go ahead and place a material there that can reestablish function again. So when we look about what dentistry has gone through, we started basically with non-adhesive materials. So that required for us to make cut the tooth in a way that teeth would stick to it by micromechanical retention, right? So what does that mean? We have to cut a lot of tooth. So we went through this process, and a lot of these materials, gold foil, for example, we see patients coming back and they're 30, 40 years old, and they're healthy, they're pretty, right? But then we started looking and we started exploring more adhesive concepts. So the current materials that we have, most of them rely on this adhesive mechanism. The advantage of that is that we no longer have to cut sound tooth structure, so we can go ahead and keep the sound structure and come up with these materials. Also, in terms of demand from patients, these are tooth colored restorations. So patients want that. I want that, and I know that there are a couple of options here that are good, but I wouldn't want some of these for aesthetic reasons too. So the big push now, in terms of where we're coming from, where we are now, is trying to make these materials self-adhere, so there's no longer need for a bunch of different steps that we do, and I'll explain that to you guys. More bioactive materials, perhaps materials that can promote some remineralization during this process of the tooth, that once it's lost, the first thing that it lost is the mineral. And coming up with concepts of self-healing and bio-inspired. So we are counting on this will be the new technology. We have people building in artificial dentin, for example, artificial enamel, as also a way to rebuild back the tooth. This is just to simplify what are clinical steps involved nowadays. So we have a tooth, we clean it up, we remove the decay, we get that prep ready, and we go ahead and we use phosphoric acid and a concentration of 37%, and we need this process so we can superficially decalcify the surface of the tooth. So this is the surface of the dentin. So what we have is that we have these dentinotubules, they're hollow, and we have a highly mineralized intratubular dentin, and in between we have this mix of hydroxyapatite and primarily collagen over there. So once we go ahead and we superficially decalcify the surface of the tooth, we have this very rich collagen-based layer. These dentinotubules become a lot more wider because we get rid of this mineral surrounding it. And then it's ready for us to start our adhesive steps. So what we use is that we use resin, hydrophobic and hydrophilic monomers that we paint over the tooth surface. After we polymerize, we'll build it up with a tooth-colored material called composites, resin composites. So what we have here when we look at this interface is that we have this material that had the ability to infiltrate. Some of it goes into these tubules, and most of it will infiltrate into that collagen and create this hybrid layer. On top of that, we have a layer of adhesive and then the layer of this composite. So we have all these phases. And this is done, so you have an idea, this process here is done in about 20 to 40 seconds. So it's a very sort of quick tissue engineering that we have. And 80% of the bonding comes out from this layer. So without really properly making this hybrid layer, these materials are going to fail a lot quicker. So the health concern, the public health concern, and why NIH has been spending some money on this, is that these materials don't last forever. In average, the current materials that we have in the back teeth, they will last about 7 years. And depending on research and how they were designed, you see clinical trials from 5 to 12 years of longevity. What is interesting to see is that the dentists now practicing, about 30 to 60% of what they do is replacing failures of these treatments. So when you have deficient margins and you have decay surrounding it, it requires for the dentist to go there, remove that restoration, place another one. It's estimated in the United States we spend about $5.3 billion replacing dental restorations that have failed. So it's a lot of money involved here from health insurances and private too. So what are the problems that we have? When we look at the tooth, it's slightly complex, all right? So if you look at the dentin, that's the bulk of the tooth, it's very similar to the bone, except that we don't have any of the cells there to promote remodeling, right? The remodeling that takes place is very minute and it's limited to the pulp of the tooth. So we're very limited in how the ability of this material to remodel. So what we have is that we have a cap around the tooth that's made, that we call enamel. And this is 96, 97% hydroxyapatite, all right? So you have these beautiful prisms. This is an etched surface in which you can appreciate all the small hydroxyapatite crystals. Surrounding these crystal apatites in the enamel rods, we have some phosphoproteins that were left there during the mineralization process, and we have about 3% of water, all right? So we need this shell so it doesn't wear. So that's how the teeth can last such a long time in the mouth. But if our tooth was all made up of this, it would crack. All right. So what we have is that the bulk of the tooth is made out of dentin, which is in the right here. And you guys already seen some pictures. So you see the intertubular dentin, the highly mineralized intratubular dentin, and that's made up of about, by weight, it's about 70% hydroxyapatite, 20% the organic content, and 10% water. When we do this by volume, it's about 50-50 mineral and organic. All right. Out of this 20%, 90% is type 1 collagen, and the other big family would be the phosphoproteins, followed by protoglycans. So when I showed you guys that hybrid layer, this is a transmission electron microscopy of that hybrid layer. So we have the collagen and the monomers, over here the adhesive. This is a basic study that we do when we want to look at the permeability of this interface. So all these black particles here are showing us porosities, and this is silver nitrate particles. So what we do is that we infiltrate that with silver nitrate for over a 24-hour period, and we section these small, and we go ahead and we see where our defects are. And what we know is that over time, where the porosities take place is exactly at this hybrid layer. So while we need the hybrid layer to be formed during the restorative procedure, it is our weakest link as well. So every process of defect initiates there. So basically what we have nowadays is this. If we don't hybridize it appropriately, you have these gaps, porosities. Over time it increases the leakage, so you have increased porosities. It will decrease the bond strength because you lose that anchorage from that hybrid layer to the dentin. And if you have that porosity, it's a wonderful opportunity for the bugs in the mouth to sit there and start another process of another decay around this restoration. So then you go to the dentist, you replace it, if that's not done again, so it gets to a cycle. So it's very often that you would see, especially in the dental school, that you may see that this patient started there at 20 years old with a smaller restoration, and now they're 60 years old and they have dentures because they lost their teeth. So we really aren't, we deal with we're not curing the disease by itself, and the materials that we have haven't been efficient to help us be effective in our treatments, all right? So the degradation processes at that interface is caused by the tooth portion and also the material. So when we look at the material, we have some degradation of these monomers or polymers. Enzymatic degradation is a big villain here. So basically we have some esterases, some enzymes in the mouth and our saliva that in contact with these materials, so slowly will break these ester bonds and start the degradation process. We also have problems with the polymerization. Most of these things are done with the light, and you never get 100% polymerization. We actually get around 60% or so. We need some solvents in here to make this material fluid enough to infiltrate over that surface of the tooth. So if we don't appropriately get rid of these, they also don't let the material polymerize as well. On the tooth side, the biggest problem is that that collagen that's so important for us is slowly degrading. And it can degrade by two mechanisms. So we have matrix metalloproteases. Do you guys familiar with matrix metalloproteases? So matrix metalloproteases are these enzymes that we have a big family of matrix metalloproteases, and they are similar to collagenase. So this basically has the ability to break down collagen very easy. Depending on the type of MMP that we have around, this process can be slightly quicker. So these enzymes are in the tooth itself as part of the mineralization process when this tooth is formed, and they're also available in the environment, right? And so if there's any opportunity that they would ever go into that interface from the oral environment, they could help in this process. There are also some collagenase that's released by bacteria, but those are kind of limited to very deep pockets into the tooth where specific bacteria do release that. Bacteria that cause decay, primarily they release acids, and that's how they decalcify the tooth. We also have water there that can also increase susceptibility of collagen degradation if this collagen was somehow weakened through the process. So basically, we have to do with these two issues. Now, as I mentioned to you guys, the environment is very harsh. So you're biting over your teeth, you're biting over your fillings that you have right now. So this process of cyclic loading, chewing, is something that is very important. So some of these interfaces can fatigue by just continuous chewing over, and a lot of that we have tried to overcome. And one thing that we have an issue with in the mouth is the chemistry, and it's the bugs in there. So we have biofilm over the surfaces. So the biofilm will create over the surface of the tooth. It will create over the surface of the material. They can be slightly different. So what do we know now? We know that the composites that we currently use, what's leaching out from these composites make these bugs more acidogenic. All right, so they release more acid, so you have a much more aggressive environment surrounding these restorations. All right. So this was a study that was published in 2010 from a group in Canada that they basically used some fluorescent microscopy here to look at the bugs. So the green are live bugs, the red are the dead bugs. But what they did is that this is when you just restore the tooth surface, so everything looks very nice and neat. 90 days later, when they incubated these in water, you start seeing some disruption, and you see the ability, you can find bugs into this interface. And when you introduce enzymes, you have really a much more drastic breakage of that interface. So now we know that we have to deal with this issue, and that's why now the National Institute of Health has proposed a new RFA to try to fix this problem with the current system. So maybe we have composites that don't create this ideal environment for the bugs. All right, so Besides that, then we talked about the substrate is an issue. When we think about reparative or hopefully regenerative concepts, we have to deal here with an existing scaffold, again, because this material doesn't really, the tissue doesn't really remodel. A big issue has always been interfaces. That's a weak link. And as I mentioned before, the environmental challenges. So our lab has been looking at this from the tooth perspective. Most of the advances in terms of the chemistry of these materials either came from the early 80s, and it's really highly guided by manufacturers. So that's where they've been tweaking some of these materials, and that comes from the manufacturers. And these materials, they change every couple of years. They come in with a different chemistry. So what we've been looking at is nobody has really spent time in approaching the tooth. How can we make the tooth more suitable for this process? So we have been exploring the use of bioactive compounds that can increase the mechanical properties of the tooth, decrease the degradation rates of the collagen, the extracellular matrix, and we also seen that some of them can mediate some of this remineralization potential of the material. Please feel free to ask me any questions in the middle. I don't mind being interrupted at all. And no biology background here. Let me know. So type 1 collagen, if I say type 1 collagen, does anybody know? The motivation behind type 1 collagen is 30% of our bodies made out of 30 or 40% of our bodies made out of type 1 collagen. So the fun thing about working with collagen is that type 1 collagen has applications in many areas. And the fascinating thing is that even though 30 to 40% of our body is made out of type 1 collagen, they're all different. The collagen has slightly modifications that make it, in some areas, mineralized, in other areas not mineralized. Some areas it'd be a lot stiffer than other organs, all right? Okay, so here we have the basic composition. So we have been particularly exploring the dentin matrix, so all the protein content of it. So we have type 1 collagen, phosphoproteins, protoglycans. So type 1 collagen, basically it has a triple helix domain, and its procollagen molecule is synthesized in the cell. It's released. You have breakage of the terminals. Then you have your collagen molecule. So the collagen molecule, it self-assembles. And during this process, it's stabilized by collagen cross-linking. And this collagen cross-linking takes place at the ends of the molecules. So basically, it stabilizes each molecule, but also between the molecules. So we have these intramolecular cross-links and intermolecular cross-links, right? Each one of these is one collagen fibril, all right? So within one collagen fibrils, we have about 300 molecules, collagen molecules, that self-assemble into a fibril, all right? So in every tissue, you will have these cross-links, but the degree of cross-linking vary by organs and the function of each organ. Yes?
Those end-to-end interactions are driven by, is it like hydrophobic? Are they charged?
These are covalent bonds and hydrophobic hydrogen bonds, primarily. And I'll go over some of those. So in this process, when collagen is synthesized, there is an enzymatic reaction. Lysyl and hydroxylysyl. I'll show it to you guys in a little bit. So basically, during this process, we have an enzyme-driven process of cross-linking, and we classify them into immature and mature. So mature collagen cross-links are covalent. So those are the ones that when they're introduced, they don't really change. The immature one, which is the most abundant in most of the organs, are primarily a hydrogen, all right? So they will form and be broken. So we have basically 5 families. So these are fluorescent ones, And there are a lot of different assays to evaluate them. Then we also have, and it's very common in diabetes, we also have the non-enzymatic crosslinks, and those are driven by sugar, right? So they can happen as we get older. So when we get older, the skin, how it looks aged, partially in process or through some of these types of crosslinks. Patients with diabetes, uncontrolled diabetes, they developed these types of advanced glycation end products, which stiffens the collagen and accelerate aging. That's why they start having problems with the eyes, with vision, because of the amount of these type of AGs. And also as part of non-enzymatic collagen cross-linking, we can introduce this. So UVA, some chemical materials, thermal and mechanical, they can also alter the cross-linking degree. So basically we got our inspiration from nature. So we realized, okay, in the tooth we have all these collagen cross-links that stiffens the collagen and reduce the degradation rate. What about if we start introducing additional cross-links at that interface, and let's see what happens. So we, in applied science, sometimes take the other approach. We look at the final result, the desirable, and then we go back and we try to understand exactly how this mechanism took place. So what we did is that, why don't we try to introduce more of these intermolecular and intramicrofibrillar collagen crosslinks? So we had a couple of candidates that we looked into, and I've never worked with natural products before, but this was one that we found in the literature that came out of grapeseed extracts. So basically these are parenthocyanidins. They're available in everything that's, in general, everything that's red will have some degree of parenthocyanidins. They're widely used as antioxidants. They're in supplements. They're free radical scavengers. And they have been used for blood pressure, so they have a lot of applications, even for tumors, to reduce tumors. So a lot of publicity these sort of polyphenols have received in the past 10 years. And the mechanism, they bond to proline-rich proteins. And the mechanism of interactions are covalent bonds. You can also have ionic interactions, hydrogen, hydrophobic. So a mix of things, which became a lot more difficult for us later on to realize how it's hard to work with this material. So this was one assay that we have to try to understand how this works, is that we used glass-coated surfaces with soluble type 1 collagen. We coated tips of AFM with the soluble collagen, and we introduced in a fluid medium, PBS, we introduced these parenthocyanidins, and we got the tip of the AFM to get in contact with the surface, and we basically measured the retraction force, how much it would take for us to pull it from the surface, like you have a fishing pole. So what we saw is that there was an intense increase in force here, retraction forces, which indicated that we have either covalent bonds or a lot of hydrogen bonds. So this has been sort of an indirect method for us to try to quantify the chemistry of how they bond to collagen molecules. What we also learned during the process of working with these parenthocyanidins is that they also interact with the protoglycans. So protoglycans, they are these proteins that you have a core protein, and you have these glycosaminoglycan chains. The glycosaminoglycan chains are very important because they're highly hydrophilic. So they're the ones that keep the tooth hydrated. So what we notice is that, we noticed this by mistake. Actually doing some FTIR analysis, we were trying to characterize these collagen crosslinks, and then we realized that all the protoglycans were gone. So there is a mechanism by which these parenthocyanidins have been removing these gags, and probably that's the reason why it also may be affecting the properties of the tissue. So right here, and it's tough to see, basically these gaps look like little hairs over the collagen fibril. They're all gone here. And glutaldehyde, we use it as a positive control for our studies.
If you go like these black areas or those,
Yeah,
what are those?
There's some it's either part of the sectioning or it was that they were concentrated. So this we use a cuproionic blue stain. So it could be something related to the staining technique that we find. And when we did this with bovine teeth, they're bigger, so you can appreciate more, but we had to prove this in human teeth too. But if you look at it, it looks like just like hair over, and it coats these collagen fibrils. So what basically it does is that there's enough water, so it keeps the collagen expanded, and it keeps it hydrated. All right, so we have also the synthetic. We have explored synthetic crosslinkers, carbodiamide. I guess for people in biochemistry lab, they use a lot doing the processing of samples. Basically, it's well known the mechanism of cross-linking collagen. It's not as powerful as the parenthocyanidins, but it's very stable over time. So wherever a cross-link, it doesn't really change. These are covalent bonds that are introduced. The drawback about it is that molecules have to be very close to each other, or the fibrils, otherwise it can't do that link. It basically initiates the process, but it doesn't participate on the final chemistry. If you rinse it off, you have as byproduct urea, so that's why you have more low toxicity. With this materials, of course, on the concentration dependent. Glutaldehyde, I mentioned before, we use that as a positive control. Again, because we also know the mechanism by which it cross-links collagen. The problem with them is high toxicity. We do have a couple of brands of materials in dentistry that do use glutaldehyde, but we just use it as a positive control. So when we look at applications of this, the first application that initiated all this process is that if we introduce more of these exogenous non-enzymatic crosslinks, we're going to improve the mechanical properties, we decrease degradation, and hopefully we get a better quality at that interface because we're going to have less degradation and more strength of that interface. So this is the first study, second study that we published in which we had glutaldehyde in different concentrations, and we had these parenthocyanidins from grapeseed extract. And what you can see, we had here a time dependent, and I'm sorry because I forgot to put it in, but basically we have baseline. So the baseline, if you cut a piece, what we do is that we cut a rectangular shape of dentin, we decalcify it, so we have only the extracellular matrix there, and we put it in the solutions, and we use a flexural model, a three-point bending technique at 3% strain. So there's no deformation, and we keep testing the same sample at different time points. So normally it has about 5 megapascal. It goes up here to 25. Eventually it will reach a plateau around 35 megapascal. So there's a reasonable amount increase in the modulus elasticity, but it sort of stabilizes. And that's a specific characteristic to glutaldehyde because it needs these free amino groups in the collagen. Once they use them all, there's no other mechanism that it cross-links. So the difference in concentration is just how quick the initial reaction takes place. So it can be as quick as 10 minutes. You would get pretty good results. Now, when we expose them to parenthocyanidins, we got, this is up to 4 hours, the last bar, and we really didn't reach a plateau, not nearly close to a plateau. So this basically shows, yes, we are probably using the same mechanism plus others. The EDC, just simply here to show. So again, around 5 megapascal baseline. It reaches a plateau around 30 minutes really, and nothing happens. This is lower than glutaldehyde, but what's interesting with all of these is that after we get these beams and we put them in water for a year, and we store them in 37 degrees, and we go ahead and we measure the stiffness again, and we saw that there was minimum variation. So that's very important for us because we don't have that ability to remodel and regenerate. So we want materials to stick to it and be stable for a long time. Now, dentin is anisotropic. So if you pull it from different directions, you will get different mechanical properties. This is the decalcified surface. And if you look at it, all these collagen fibrils, these are the dentin tubules, they sort of try to run on a parallel orientation or some sort of organization. So what we did is that we tried to pull them in different orientations to see if there was any variation. And what we notice is that for our parenthocyanidins here, regardless of the orientation that you try to pull this in tensile, it really didn't affect the overall ultimate tensile strength. But for glutaldehyde, it was more pronounced on one orientation. And we hypothesized that that's likely due to the orientation of these crosslinks that are induced, that when they are in shear stress, they break a lot easier than in tensile. So this was interesting finding for us because when we tested at ultimate tensile strength, we would never get a positive response from glutaldehyde, even though we could see that the matrix was stiffer. This is very important for us in the tooth because of the three-dimensional ability to restore it. So if you're restoring one side versus the other, you may get different results. And this is a cross-section of a tooth that has a decay, all right? So normally when there's a decay process, the enamel starts looking very chalky, and when you look into the dentin, it has sort of this triangular shape. So it spreads through this interface a lot quicker, and then it tries to go straight to the pulp. So down here would be the pulp of the tooth. Once it reaches the pulp of the tooth, that's when you need a root canal, basically. So we don't want to get there. We want to stop earlier. So what we try to do is that most of the time when you work with these materials, we don't test healthy tooth. You're not drilling into a healthy tooth. You're drilling into a decayed tooth. So we wanted to see how much this, if there was an effect of site location. So we use a nanoindenter that we have up in the lab, which allows us to really track different areas. So we cut this in, we superficially decalcify the surface of the tooth, then we go ahead and we start doing these indentations. And to just summarize what we've seen is that this is a percentage increase, so we get a percentage increase in the reduced modular elasticity of about, I think, 200 to 250 times for glutaldehyde and EDC, where we get for grapeseed extracts about 5 up to 4,000 times. But what was interesting is that it reinforced more significantly where the decay process was taking place. So it reinforced already that damaged surface. And this for us is very valuable because that's where we're going to be using it more. And the reason for that is that collagen, where the decay process was taking place, was already being partially degraded and lost some of those crosslinks. So there was an ability for it to promote even more cross-linkage. Then when we look at a quick and dirty way to do some of these evaluations in the lab is we purchase collagenase. We use a buffer where we activate the collagenase over a 24-hour period. And what we get is that we get these extracellular matrix and we test them first. We look at their initial values. Well, actually, this was ultimate tensile strength. So we had samples that we broke right after test, and then samples that we put it in collagenase, and then we break it. So what we notice is that our controls, they're fully degraded. So there's not even a sample there to test. While our treatments, regardless of the treatments, you're able to test it. So it shows us this indirect assessment to show the increase in biodegradation. Decrease in biodegradation. The same here is true. This is just for the EDC. So Well, first we were more interested in the mechanical. We start looking into this ability to, the biodegradation is probably even more important than the strengthening to the mechanical properties because of this ability to stabilize it over time. This is where we talked about these MMPs. So what we do is that we also use the same beans. We basically collect everything from one of our tests. So we collect the supernatant, so the water that these materials were stored, and we use a hydroxyproline assay to detect solubilized collagen in there. So this is an example of materials that they were left, I think, for 4 weeks. So in the water of the control beans, we get a lot of hydroxyproline. Chlorhexidine has been used as a well-known MMP inhibitor, and we see a great decrease, but with the grapeseed extract, it was 4 times better than already the chlorhexidine. And this is just another indirect method to evaluate MMPs in which we look at that content over a 9-month period, and we see the amount of degradation over the control and the stability of those matrices. There's really very few degradation going on after treatment. I'll skip on this. So the clinical application, when we look at it, which is important for us, is that we test this bond between the tooth and the material. So we cut flat the surface of the tooth, we build it up with this composite. We cut them into small beams about 1 by 1 millimeters thick, and we pull them, and we call this test a microtensile bond strength. So with this test, we have the ability to decide where we want to cut it. So we cut in the dentin that's very sound, never had a decay, and the dentin that had a decay process. So when we look at you already see a difference between sound and decay. So the bond strength of the decay is already significantly lower than the sound, right? So when we introduced glutaldehyde or grapeseed extract, we saw an increase in the bond strength for both, and it was also more pronounced on the cancer-affected dentin. So the add per single bond in one step, those are 2 different commercial brands of bonding systems that we use. So what we saw is that it wasn't material dependent. It really behaved the same regardless of the material. The problem is that when we started looking at this, we didn't know how long this cross-linking mechanism needed. We're talking about like a 4 or 5 micron surface that we play with, but when we started doing these microtests, we're looking at 500 micron thick samples, so we're using about an hour to get some results. So we start doing our test using 1-hour treatment, and that's like not feasible clinically at all. So we start having to look at concentration-dependent effect. And what you see, unique to the grapeseed extract, is that the higher the concentration, the quicker the response. So we compared with the usual concentration that we use versus a 30%, and we used it for 1-minute application. So when we use it to 1-minute application, you see only a statistically significant increase with a 30%. So we know that we need to use a higher concentration. That would not have been true for the other compounds.
So when you put this in, if I understand this, you put grapeseed extract down for a minute, and then you put down the adhesive.
You rinse it off, and you put the adhesive. So this is like a baking recipe. So you have to go through these steps. So you etch, you rinse it off, the etchant, then the surface has to always be moist, and you introduce the solution with the 6.5 or 30% grapeseed. Then you rinse that off, then you introduce your bonding system over this moist surface. The problem is that right now the way we need some moisture over the surface, otherwise we can't create that hybrid layer because the collagen won't collapse. All right. So this increase in bond strength was more predominant with the higher concentration. Then we wanted we want to characterize individually all those layers. So we take advantage of nanomechanical properties. So we go with the nanoindenter and we track back, we can localize the underlying dentin, the hybrid layer, the adhesive layer, and we can look at them. And so what we notice is that for glutaldehyde, for example, it increased the modulus elasticity of the underlying dentin too, because it really has the ability to infiltrate even a mineralized tissue. While these proanthocyanidins, they're higher molecular weight, so they don't have the same ability. So we've seen a more significant effect in terms of the underlying dentin for glutaldehyde. The grapeseed didn't have any major effect. The hybrid layer, around 9 gigapascal for the control, and it went up significantly for the two groups. So we've been using this test. It's tedious, it's tough to find it, it's not always the same thickness in every section that we do, so this takes a long time. So when we get to this stage, we are working with just a couple of groups. And we also explore the sealing ability. So this is very important for us because the surface, even if it's not strong enough, but if it's sealed, it's good enough for us. So what we do is that we go into the confocal laser microscopy. We use rhodamin as a fluorescent dye, and we seal everything around except that interface. We leave it there for about an hour, and we take it to the confocal immediately. And the collagen, most of the non-reducible collagen crosslinks are fluorescent, so you can pick them up too. So now we use this as a method to characterize the degradation over a period of time and correlate the degradation of this collagen with the porosities over that interface. So this was presented, this was work with one of our students, postdocs, and basically we have all our different groups of evaluation, and then we compare. This is the rhodamin. So we saw that one material has a lot more permeability than the other material, but the different treatments really did not affect. Glutaldehyde was the one that showed the highest amount of red fluorescent, which is the collagen cross-linking. So the type of cross-link that they induce are most commonly the fluorescent, followed by the grapeseed extract. The EDC, we really didn't see any difference in the fluorescent when compared to the control groups. Now, in terms of reducing permeability, we saw a significant decrease in permeability for the grapeseed extract and also for the glutaldehyde when we compared to the control. And that was primarily true for one system, not this system. We do have we're doing now a 2-year evaluation of this. And so we have these samples aging there for 2 years, and we go back and we look at this. And the results are pretty amazing for us, because what we're seeing is that on the control, the collagen's going away. You can't detect it no longer. While the permeability increases over time, but not in the same, then it's treatment dependent. I just didn't have time to put it in here. All right, so this has been the bulk of what we're doing. I want to say 80% of what we do in the lab is focusing on dealing with this interface between biomaterial and tooth. Now, we have explored the use of these crosslinks to benefit minimal invasive dentistry. So what is that? We don't put any material that replaces. We induce the tooth to remineralize again, right? So how can we do that? We basically reduce biodegradation rate. So the collagen is the backbone for mineralization, right? These are also calcium binding, the proanthocyanidins. So they can work as a phosphoprotein analog. So the phosphoproteins are in charge of this mineralization process. So if we can slow down degradation and have it there to help attract calcium, maybe we can develop a new strategy to remineralize teeth. So probably the most common thing you guys have heard about remineralizing teeth is fluoride. So your toothpaste has fluoride because the fluoride makes the mineral in your tooth more acid resistant. All right, so that's like the most well-known strategy to remineralize tooth or to prevent teeth from decaying. all right? But even though with all of this, the United States has been an increase in amount of decay in kids, actually. So it's not 100%. And there's a lot of issues with fluoride and toxicity, especially for kids. So these are like decays that we introduce on the surface. We simulate this in the lab. We create an environment that introduces a acidic and a neutral environment. And we can go to the polarized light microscopy, and we can measure the lesion. We can identify different areas of the lesion. Then we go into the confocal, and we use the Rodman to help us look at the intensity. So we look at the degree of demineralization based on the intensity of the Rodman. So what we've seen is that once we introduce the grapeseed extract, it really improves the remineralization potential. So these lesions, they start getting smaller, all right? So this is the control, this is fluoride. So it's behaving very much like fluoride, but in a different mechanism. It actually makes this surface a lot harder than what you would get with fluoride. And this is just another probably easier way to see some of this mineralization process. So this is a highly mineralized surface. This is the lesion. This is your control. This is grapeseed. Grapeseed associated with fluoride and fluoride by itself. So we look at the mineral loss by using microradiography, and we can quantify this mineral loss. So what we observed is we even had done some studies that we introduced some collagenase that you would expect some of that degradation to take place in the mouth, and we've seen very promising results with this. So this is what we've been cooking in the lab, and hopefully we'll send a proposal in. And then we can use fancy tools like the CT scans to look at the remineralization. So surface that lost mineral, part of it we coat it so we have a reference point, so we coat it with nail polish. Then we try to remineralize, and this is starting the remineralization process over the surface. Okay, so basically this looks like a heart, and for us it is the pumping power in the lab right now. So these are these parenthocyanidins. We have type A and type B, and this is the basic chemical structure. So I know very little about this, and that's where we built an interdisciplinary group. We have pharmacy at University of Illinois there, has a wonderful botanical institute that was sponsored for NCAM from NIH. And basically they're one of the best people around to actually characterize and tell us exactly what's in these compounds. So we wrote a grant together, and the deal is that we want to know where in this grapeseed extract, where are my active compounds? So if I get these active ingredients, then we can start building an intervention material. Every time you work with a natural extract, depending on how much it rained, how warm it was, they vary. So they're never the same. And we see that by different batches. They even have different colors. So you can't develop anything that way. So we've had a year now into the grants, and we have another 4 years to try to narrow as much as we can of the active compounds. And what I've learned from the pharmacy folks is that even though the chemical structure is the same, basically there's a polymerization process, so they become bigger. It's like Lego. If you position it in one way, it will have one property. If you change it to here, it already behaves differently. So this is where we've gotten so far. So we do get these compounds. We had some sources of cocoa. We've used different sources of parenthocyanidins. And this is some of the characterizations that they do. So we do a fractionation on Cephanax, and then we go to an HPLC, and they look at the degree of polymerization. So you have catechins. They are the simplest, are monomers. You have dimers, trimers, and you go all the way. The dentin activity is a bioassay that we use this stiffness method for the mechanical properties. And this is basically, I don't get anything, I don't get negative, and we start getting a lot of activity on around this area, which is the higher molecular content, what they call oligomeric parenthocyanidins. Of course, they're the hardest ones to work with, and that's how we figure out that people haven't worked with them before, but for a reason. So this is just an example. Then we use that stiffness method, and we look at different times point, and we look at the stiffness of the dentin. So this guides us. So what we did is that we got these two fractions at the lower end, fraction 4 and 5. Then we went ahead and we fractionate those in 20 fractions again, and we start seeing where the activity is. Then we get these and we fractionate them again. And what we've seen so far is it's not going to be one compound, of course, but hopefully we can get a couple together and pump up, maximize activity by concentration, and then we have a intervention material. Basically, I said the other challenges, and I've been talking to Scott before we came here, is we have this material, now we have to make them deliver appropriately. So delivery systems are the next challenge. I've seen people functionalizing some of these or trying to functionalize some of these compounds, especially DC, that's already synthetic, very simple in a way, and to try to introduce them into this polymers that we currently have and monomers that we currently use in dentistry. So this is the lab group. There's a bigger list. Some of our collaborators within UIC, some people in the other areas, and a nice picture of Chicago, so you guys should come and visit us there at some point. That was all. Sorry I had to speed up.
Questions for Anna?
Yes.
I have two questions. One is more, I'm curious about this decay process. Is it, so does it start with the demineralization first, and then it goes on and attacks the collagen?
Yes.
Sort of, yeah, so that's sort of the
Very good. So you have to have an acidic environment. So because the mineral protects everything. Okay. So as you get the mineral out of the way, the bacteria becomes more invasive, so it has more space. It becomes harder for people to clean it. And slowly the enzymes in there will start degrading the ECM. So the ECM kind of holds it in place too, because it makes it a lot harder for things to diffuse. But as it breaks down, it accelerates the process. But you need to have acid there first.
And then my second question was more about, how much is not about the structure of these things. So you showed that like these collagen bundles tend to orient like parallel like these. Is it known how many, and I guess the decay process starts by sort of the disassembling of that sort of structure. Is it known how many collagen units are in each of those bundles that are parallel?
So
on average?
about 300 molecules. Okay. So the way they self-assemble, if you look at them on the SEM, you see stripes.
Right.
And because they self-assemble in a very unique way, it's a good question. I don't know specifically for these, but we have normally a number for initial formation of these fibrils around 300.
Okay. So those fibrils are very
organized.
And all the same.
All the same.
Diameter.
So when you look at when they start denaturing, they lost their 3D conformation. When you go to the SEM, you will see it. Once you lose that bending, then you know it's basically gone. It's useless. It's gelatin. It turns into gelatin.
I have a question on the remineralization. The GSC, if I read it right, doesn't really promote mineralization, right? It's just preventing decay.
Basically, what we saw two aspects. The first study, we created a lesion, and we tried to remineralize it. And the other one, we used it to prevent the lesion to develop. So you kept treating the surface of the tooth and inducing this acidic environment. And for both, we saw a positive effect of the grapeseed. So initially, we were focusing primarily on the degradation. So if it doesn't degrade, even ions to diffuse would be a lot harder, and it stiffens the matrix a little bit. But then we were doing some reading, and we saw that they're chelating agents. So they are calcium binding, and on this saliva, you have the calcium and the phosphate, and when you have enough of both, so you first need the calcium for nucleation and then the phosphate, that's in the environment, it starts inducing, creating these amorphous calcium phosphates that will later on turn into crystals. But we have not gotten to that far in showing that you have actually hydroxyapatite crystals. So right now, it's just based on hardness values that we get over the surface, or some of that microscopy that we did confocal.
On the teeth studies, of course your teeth change throughout your lifetime.
Yes.
Do you select a certain age?
Yes.
For each of these?
Very good question. So what we do is that most of these teeth are wisdom teeth. People come to extract them between your age. So I'm sure everybody had gone during summer, got their wisdom teeth extracted. So those are the teeth that we use. So what happens, there is a very nice study when I was in North Carolina, the group was doing it there, that compared age ranges, and older patients, and you can see teeth are yellowish. It's part of this process too. So they have more collagen cross-linking. Biological tissue, there's a lot of variation. That's our N has to be, what we do is that we work at 15 teeth, and we get a slab of each tooth, we get a slabs, and we put it in different groups. So we try to keep that variable constant.
Do you think, actually, just to follow up, do you think it'll be more effective or less effective for older patients?
Probably slightly less effective. So the studies that we're doing with decay, we're actually targeting elderly population. We are doing studies with root decay, because the enamel on the crown of the tooth that you guys can easily see in your mouth, that enamel surface, we're not exploring the use of these materials. So we're looking at, as we get older, we get some root gum recession, and that surface actually, it can decay a lot quicker than the crown of the tooth, because you don't have that highly mineralized enamel surface. And people are living a lot longer. So actually, in the United States now, it's ridiculous the amount of new root caries. I mean, there's a huge percentage increase in root caries in the elderly. And because they're so close to the pulp, it can be so quick, that reaction, that a patient can lose a tooth in a year. So that's why we've been particularly interested on that root surface.
So is there any effect of roughness on the tooth surface for how easily you can repair the interface?
Very good question. For the current system that we use, to a certain extent, we normally standardize, and you standardize that by a polishing technique. So we try to simulate what a burr would do on the top of the tooth. So it gets to a 600 grit surface, and that's sort of the roughness that we work with. But it will help with some of the micromechanical retention of irregularities, but you would still need that hybrid layer.
All right, let's thank Anna one more time.
Thank you.
Looks like we have coffee in the back. Nice cookies. That's great.
Okay.
Thanks a lot. There's nothing like sitting in front of you for an hour to learn everything I need to know. Read these papers a little bit better now.
All right. So let me. I can give you this lecture if you want. Is it okay? I can just I can either PDF it or transfer to you right now. So